So you found out that you need a knee replacement and you're wondering about whether or not you should have a robotic total knee replacement, and you probably have lots of questions. So in today's video, I'm going to tell you everything that you need to know about robotic total knee replacements. All right, well, welcome back. I'm Adam Rosen, and thanks for tuning in. If you have not already, please subscribe and please click the like button so people like you that are searching for information like this find this kind of information. So in today's video, I'm going to probably go down the rabbit hole, and I might tell you a lot of information that might seem confusing, but I'm trying to give you all of the information that I think some people might want to know, but it may be a little overwhelming for some of you, so I apologize in advance. Before we talk about robotic total knee replacement, I want to take a step back. So historically, we used to do what was called a manual total knee replacement, and what that required typically was a rod that went up into the thigh bone and down into the shin bone, and attached to that rod were jigs, and once we attached those jigs to the bone, we could then use a saw to make the cuts to do the knee replacement and implant the parts of the knee replacement. Now, normally in a knee, the knee joint is actually tilted by about 3 degrees in most patients. And it was hard for them back then to make a cut that was 3 degrees off of a straight rod. So what people did is they took 3 degrees out of the shin bone and 3 degrees out of the thigh bone to make the joint parallel to the floor to keep the limb aligned, but it threw off what we call the kinematics of the knee. It threw off the ligaments as you would try to bend and straighten your knee. And a lot of the studies back then showed about an 80-85% success rate. So 15 to 20% of patients were dissatisfied. Now there's a number of other ways of doing it. You can do what's called anatomic alignment, or what has been popularized more so in the past decade or so is what's called kinematic alignment. And this has really been popularized by a doctor named Steve Hall in Northern California. And when he first presented his x-rays to our academies and the joints were tilted, everybody gasped and everybody expected it was going to fail, because we had old studies that predicted that if the joint was tilted more than 3 degrees, those knee replacements had a higher failure rate. And it was because the plastics were very thick back then and the bone cuts were very thick. So the implants were put into softer bone. Nowadays, we're taking very, very little amounts of bone, and that allows a stronger bony surface for the implant to attach to. So even when he had these joints that looked crooked, it was mirroring the patient's normal anatomy, so it retained their normal kinematics. And there's been a shift into that direction, but this is going to scare you. What I'm going to tell you is we do not know what we're doing. And what I mean by that is we know how to go through all of the steps of a total knee replacement, but no surgeon can reliably look you in the eye and tell you exactly how we are supposed to implant knee replacements in you. We have an idea, many of us have theories, and a lot of us have experience. But the problem is that if you do an old-fashioned manual knee and it looks fine on x-ray and you have pain and you get a second and third opinion, everyone's going to go, it looks fine. You know, I don't know what's wrong. Your x-rays look okay. They should be examining you too to look for other causes. But you'll hear that from a lot of surgeons, that it looks fine on x-ray. And when surgeons started doing kinematic knees, if the patient had pain, other surgeons would look at it and be like, oh, I know why you have pain. They put your knee in crooked. Now people are accepting of this idea of kinematic alignment. So when the joint looks crooked, nobody jumps the gun and says that's the reason why you hurt. We also talk about something called gentleman's varus. So a lot of men are bow-legged, and for a number of years, even people that did mechanical would sort of err a degree or two into a bow-legged sort of knee, what we call a varus knee. And even now, if you're very knock-kneed, what we call valgus, or very bow-legged, called varus, there is not a clear understanding, should we make your leg straight, or should we leave it a little bowed or leave it a little knock-kneed? And that's the difficulty, because when we talk about technology, the first technology advancements that we had were in the early 2000s. And it was what's called computer navigation. And this allowed us to measure all of the bony surfaces and the alignment of the leg and the tension between the ligaments. And what we found is that you could be very accurate. So if you wanted to put a knee like this, you could put a knee like that over and over and over again, but nobody really knew what the target was. Again, we don't know personalized if your knee should be like this or if your knee should be like that. So we make our best guess based on your normal anatomy and based on how the knee feels and your ligamentous balancing. And that's because in our world, there's a lot of things that work well. And now knee replacements, for the most part, 90% of patients are very happy and they have successful outcomes. But there are still a number of people that have knee replacements and they are not happy or satisfied with the knee replacement. And what I've unfortunately seen is when I see a lot of second opinions, patients were told by their surgeon that I don't know what to tell you, I used the robot. So there's a lot of surgeons that feel that whether or not the patient is happy or not happy with the outcome, that because they used the robot, they didn't do anything wrong, and you're not supposed to have pain. So that becomes sort of the gist of how we got into robotics. And when we talk about robotics, we're not talking about the surgeon standing back and a robot is performing the surgery. What we're talking about is what's called robotic assisted total knee replacements. And there's three big players in the market. Stryker has a robot called the Mako robot. They bought this in 2013 for $1.6 billion. So this is a huge investment. And when this first came out, you had to buy those robots, and you were looking at a capital outlay of $1 million or more for the robot. Now, many of the companies now give robots basically away if the surgeon is going to use their implant. So with the Stryker robot, you're implanting the Stryker knee, which is called the triathlon. That is CT based. So if you have a Stryker knee, you first need to get a CAT scan, and they base a lot of the information off the CAT scan that they upload into the computer before you actually have the operation. Now, there's two other big players in the market, and these do not require a CAT scan. So Zimmer bought the Rosa robot in 2016, and they used the knee called the Persona. And then DePuy came out with the Velys robot in 2018. So again, neither one of those require a CAT scan to do the actual operation. Now, both the Stryker robot and the DePuy robot have a saw attached to the robotic arm. So with the computer, the surgeon is using a trigger to activate the saw to make the bony cuts that are required to do the knee replacement. Whereas in the Zimmer Rosen knee, the robotic arm is moving the jigs, and you're still using a saw to cut through the jigs to perform a knee replacement. Now, are those the only technological options that are out there and available? No. One of the other big players is what's called handheld navigation. There's a company called OrthoAlign, and their latest invention is what's called the Lantern. And it basically looks like a smartphone, but it allows you to collect all this data on alignment and the bony resections and the ligamentous balancing to perform the operation. And the surgeon is still using a saw, but they're using this technology to align the limb the way that they think the knee needs to be aligned and to balance the knee the way that the knee needs to be balanced in their mind. The other two interesting players that have come to the market are what's called augmented reality. And what this is the surgeon wears a helmet, and the helmet reads sensors that we use during surgery to assess the limb alignment. There's one company called Pixie out of France. They're what's called open platform, meaning that you can use their augmented reality on any knee system. So whatever knee system the surgeon's using, they can use this augmented reality platform and do the angles and the bony resections that the surgeon wants to do. There's another player on the market. This augmented reality platform is called the Arvis. This is one that I was involved with when it came to market, and it is produced by a company called Enovis, which more people know as Donjoy, and they use one platform which is used for their knee, but they also have an open platform option where you can use it for other systems. And what's interesting about these augmented reality platforms and the handheld platforms is they're portable. So if your surgeon goes from hospital A to B or works in a surgery center, you can easily take a helmet or a handheld device with you. if you work in different hospitals, a surgeon cannot just pick up the robot and the array and the monitor and simply throw it in the trunk of their car and take it to the other hospital. So some surgeons were sort of pigeonholed into only doing robotic procedures at one particular hospital if that is where the robot lives. Now, studies. I don't want to bore you with studies. I'll probably put some links in the show notes if you're curious, but you can always go to PubMed, which is the clearinghouse essentially for all scientific information. And what you're going to find is if you search up robotic assisted or robotic total knee replacements, you're going to find basically 3 outcomes. And the first outcome that you're going to see is that surgeons have found that robotic total knee replacements lead to better outcomes and less outliers and better what we call patient-reported outcomes around 2 years. So what they're saying is early results show that robotic surgery is good. If you keep looking, though, you're going to see a whole bunch of other studies that have found no difference when they compare robotic total knee replacements to manual total knee replacements. They're going to say there was no difference in the outcomes when it comes to patient-reported outcomes or surgical outcomes or complications. You're going to see another set of studies that look at what are the downsides, and they're going to say that there's no difference, but they don't recommend robotics because of there's increased cost. There's the cost of the robot, cost of the instruments, in certain cases the cost of the CAT scan. They've also found that a lot of robotic surgeries do take longer. Many surgeons that I know that have done many robots over a period of time, it becomes time neutral, but many times the surgery is going to be longer when you're using the robot. And the other thing that some of these studies do show is what's called pin track infections or pin track complications, pin track fractures, because when we're doing these computer assisted procedures, what we have to do is put pins in the thigh bone and pins in the shin bone, and attached to those pins goes trackers, and it's the eye of the robot that looks at those trackers, and that's how we actually determine the limb alignment and the balancing. But what happens is when you put those pin tracks in, a patient can develop an infection at the site of those pin tracks, or in certain instances, because we've drilled holes in the thigh bone and the shin bone, patients have done therapy, and that has resulted in a fracture occurring. Now, the thing I want to share with you too, it's interesting from a salesman perspective too, because as a surgeon, I see salesmen all the time, and they come and they talk to surgeons in different ways. So many times, especially early on, salesmen were coming to surgeons and saying, look, you need a robot because it's basically free marketing. Every patient out there is going to hear about robotic total knee replacements, and they're going to come to you if you're the guy in town doing robotic total knee replacements. The other thing they did was scare tactics. They would say, hey, hospital B down the road already has 2 robots and you don't. So if you don't buy a robot, you're not going to keep up with the Joneses and you're going to lose income because patients are going to stop coming to you. The other big thing that they stressed, and this is what's been shown in studies with all of the navigation options, is they'll tell you that the robot can reduce your outliers, meaning you can better align your knees and not have knees that are outside of the norm, which we know can cause pain or problems or the need for an early revision. Now, many surgeons that have been doing this for a very long time and are very experienced do not have outliers. So they really marketed the idea of we can get rid of your outliers to doctors that were young or inexperienced or doctors that did not do a lot of total knee replacements. A lot of knee replacements are done by surgeons that don't do a lot of knee replacements per year. So you always want to find someone that's doing a lot, 50, 100, preferably even more than 100, more than 200. And with that experience, they tend to get better outcomes. And the problem that many surgeons had, if you were experienced, is we would say, hey, look, if you introduce this robot and this screen and this technology, it becomes data overload for a surgeon that is not very experienced to begin with. And there is more risk of them kind of taking their eye off the prize. And they can be distracted by the technology. And even though you're telling them that they're going to have less outliers, It leads to increased surgical time, which we know causes an increased risk of infection. And because they're looking at all these gadgets and numbers and screens, they might not do as well of a job at the actual site of the surgery at your knee because they're focused on other things. What is also scary, if you talk to surgeons that are experienced in our sort of little world, that there are a lot of residents that are coming out of surgical residencies that have only done robotic total knee replacements. They actually haven't done any manual knee replacements. So they lack the ability to do a manual knee. They lack the skills that they learn by using the saw and understanding what the cuts are supposed to look like and how to manually feel what a well-balanced knee is. So when they go into practice, if they don't have that experience, they're basically learning when they're in practice as a surgeon. And without the robot, they are at much greater risk of making a mistake or making an error. The other thing that I've heard from people, I don't know personally, like firsthand, but I've heard stories of surgeons at their hospitals of talking about a young surgeon who was using the robot and the robot went down for some reason. Either the tracker came off or the computer just malfunctioned or there was some issue with the power and they couldn't convert back to a manual total knee replacement. And they basically closed the patient up and sent them off to the floor and brought them back on another day to redo the operation once the robot was up and running. And that is concerning because if you're a patient on the table, you want to know that your surgeon can take care of you, even if the technology fails. And the other thing that really kind of bothers me at times too is I've seen a lot of second opinions where patients have not been happy with the outcome. For whatever reason, they've had some issue and they come to see me for a second opinion. And over and over and over again, I've heard from patients that their surgeon has just said, well, I don't know what to tell you. I used the robot. So they're basically saying it wasn't my fault. I used the robot, so it's supposed to be perfect. It's what the robot says, and you're supposed to like it. But what we know is there's a lot more to a knee replacement than just a whole bunch of numbers. It's soft tissue balancing. It's attention to the soft tissue. It's obtaining a range of motion. It's trying to restore the normal alignment and the normal kinematics to the knee. And that's the thing still that we want to know is, if you're bow-legged, should we leave you a little bow-legged or should we straighten you? If you're a little, knock-kneed, should we leave you a little knock-kneed or should we straighten you? And where are we supposed to put the knee? So not just 90% of people are happy, but 100% of people are happy. And maybe that's unrealistic, but maybe 98% of people are happy. So in summary, when we talk about downsides, the downsides of a robotic total knee replacement is there is a learning curve. So you don't want to be the first, second, or third patient that a doctor uses the robot on. And there is an increased cost. And many times that's absorbed by the hospital. But you do want to find out if your insurance covers it. And if they don't cover it, because sometimes they'll pay for a knee replacement, but insurance companies won't pay for the navigation portion. It's a separate code. You want to find out if you're going to be billed for that. And if you're using a CT-based robot, you also want to find out whether or not you're going to be charged or billed for the CAT scan. The other thing, again, is it can increase the time. And although I know some surgeons that have gotten to time neutral, and a few that have actually found that using the robot, they're actually faster, there usually is going to be an increased time for anesthesia and surgery if the surgeon is using the robot. And again, pin track complications, such as fracture or infection. Now, what are the advantages of a robot? So there's definitely some people where the robot or some type of navigation is extremely important. So these are people that have a significant deformity. Maybe you had a fractured thigh bone when you were younger and your thigh bone's crooked and your limb is S-shaped. So trying to figure out where to put the implants to best restore your alignment and kinematics, a robot or some type of navigation is extremely useful and almost mandatory. The other thing is patients that have hardware. So maybe you broke your hip and you have a rod in your thigh where we can't instrument it with a manual instrument. That's where technology or a robot is extremely helpful because we don't then have to go and do a second surgery to remove that hardware. And the other thing is reducing outliers. So if someone's very good with robots and let's say they're not super experienced doing knee replacements and when they look at their data, they actually do have these patients that are outliers, patients that they left too loose or too tight or too knock-kneed or too bow-legged. Using technology of some sort might narrow the field and reduce the number of outliers, which hopefully should result in better outcomes in their patients. Now, the reported claims of patients that have robotic-assisted total knee replacements having less pain, shorter recovery, better range of motion, not necessarily due to the robot. Now, maybe if your surgeon was not doing a good job with a manual instrument and the robot did make them better, maybe in that patient they had better outcomes. But in a lot of patients, what we have seen compared to years past is that the improvements in pain management protocols have resulted in less pain. The improvements in anesthesia have resulted in less pain. The improvements in physical therapy have resulted in better range of motion, shorter recoveries, and better outcomes. So when someone had a knee replacement 10 years ago and they had a really rough time, and they had a robotic total knee replacement today, and they're telling everyone how the robot made their recovery so much better, quicker, faster, it's not just the robot, it's that everything has changed in the past decade. Pain management protocols, anesthesia protocols, physical therapy protocols, all of those advancements have led to better outcomes overall. Now, couple other things that from a surgical standpoint, surgeons talk about sort of behind closed doors. So many surgeons who are experienced that use the robot, that love the robot, will tell me and tell others why they love the robot and they're doing so much better with the robot and they wouldn't ever go away from the robot. And it works well in their hands, and that's great. That's excellent. There are many surgeons, and more so in the experienced field, that talk about how they did use it, but they didn't really see a big difference, or it cost a lot of money, or they got frustrated with the footprint because you have this huge robot sitting next to you at the table, and then there's another arm or array with trackers that tracks the beams. Then you have another screen, and then there's usually a rep, so it becomes a lot of stuff and people in the room, and some surgeons just get frustrated by having all these things in the way. And they found sometimes that it slowed them down. So they have a number of cases on the day, and then using the robot, having the robot set up, having the robot taken down, maybe moving the robot from room 1 to room 2. It's kind of slowed their whole kind of workload down, and they've decided to go without it. But many surgeons are concerned about a lot of these younger surgeons that are learning how to do robotic total knee replacement, which is great because you can look at numbers, and when we explain things to them, they can visually see what we're talking about. But by lacking the skills to do a manual total knee replacement, there is a fear that there is a greater risk of complications in the future, especially if robots fail and surgeons don't know how to do a manual total knee replacement well. And that's a lot of information. So if you've gotten this far, thank you for sticking it out. I hope you found all of that information sort of helpful. And what I did to kind of close is I came up with 10 questions that you can ask your surgeon if you're going to be having a total knee replacement and you're considering robotic. Maybe they do robotic or don't do robotic, and you want to ask appropriate questions. And you may not ask all of these questions, but they're questions that I think would be helpful. So number 1, do I need a robotic total knee replacement? Because again, many knee replacements can be done without a robot, but in certain instances it's helpful, or in certain cases mandatory. So you may want to ask the question, and do you need a robotic total knee replacement? I would hope that if you had a complicated issue and the surgeon you were seeing doesn't use any technology, that they would tell you that technology would help produce a better outcome and maybe refer you to someone that uses some form of technology. The second most important question is, if you're having a robotic total knee replacement by a particular surgeon, is ask them, how many robotic total knee replacements have they done? This is something that I even tell patients when they're having knee replacements anywhere, is asking a surgeon how many they've done and how many they do per year. But again, you don't want to be the second or third robotic total knee replacement that a surgeon does do, because there is a learning curve. And I don't think any surgeon should be caught off guard if you ask them that question. The other question is a little techy, but you might want to ask is, do they put the pins into the incision area, what we call intra-incisional pin placement, or outside of the incision? And will you have other scars? Because we will have the incision from the knee replacement, But if they put trackers outside of the incision, you're going to have other poke holes and incisions in your thigh bone and your shin bone that have to be closed and have to heal. And you may want to know that ahead of time, as opposed to waking up and finding other incisions in your leg and wondering how they got there. Next question is asking a surgeon, what do you do if the robot goes down or the robot is not available? So if you're scheduled for a total knee replacement and for some reason the robot was out for maintenance and it's not there, are they going to cancel your surgery, or do they have a backup plan? And the same thing holds true if the case is going and we're halfway through the surgery and the robot fails. Does the surgeon have the instruments and the ability to then transition to a manual total knee replacement to complete the job? Next question is, what is the cost? What is the cost to you? Because again, some insurances will not pay for the robot, and you want to make sure that you're not going to then be billed. Some hospitals will just absorb that cost. And also, if you need a CAT scan, will the insurance pay for the CAT scan? And if not, what is the cost to you to get the CAT scan? Next question, asking them how much longer their robotic total knees are compared to manual total knees. Because especially if you're older and there's medical issues and time under anesthesia is a major concern, you want to find out whether or not this is 10 or 20 minutes longer if they use the robot versus not using the robot. Next question, again, this is kind of a techie one, but maybe asking the surgeon, what are your goals for alignment and balancing? Like, what are you going to do to replace my knee, and how are you going to align my knee? And some surgeons, might go into a lot of detail, or some might be a little bit more short about, hey, we're just trying to do this or that, make your leg straight, get rid of the crookedness, we're going to, make these ligaments balanced. But it's a good question to ask. The next question would be, if they're doing a robotic total knee replacement, is which robot do you use and why? Because again, it's going to dictate what implant they use, especially if they're using the big three. And many surgeons that are comfortable with a particular implant then start using that company's robot. But there are some surgeons that have many, many years of experience with company A, and because they wanted to use company B's robot, they switched over. So now they're using an implant that they might not be as familiar with because they like that robot. Next question is asking the surgeon, do you see better results in your robotic total knee replacements? I'm guessing every surgeon is going to say yes that does robotic total knees, but it's a good question to ask, and they might tell you yes or no, or they don't see a difference in these patients, but they do see a difference in those patients. So it's a good question to kind of bring up. And lastly is sort of that general question. Any other questions that I should ask? I always tell patients that's a great question to ask, because it allows a surgeon that may not have told you something to kind of spill that information at that point. But also, what are the pros and cons? You can ask a surgeon, what are the pros and cons from your perspective as to why you do or do not use robotic total knee replacements when you do these surgeries? So that's a whole lot of information. It might be more than you were looking for, but I hope that you found it all useful. Hopefully the questions are helpful if you're going to have a knee replacement and you're going to see a surgeon and you're contemplating robotic total knee replacement. But the main gist of this is for the vast majority of patients. You do not need to get in a car and drive 100 miles to get a total knee replacement done by some surgeon that uses a robot if the surgeon in your town does a manual total knee and has lots of years of experience and is very technically sound and has good results and outcomes, because the majority of studies have not been able to prove a long-term difference. We might find that out in 20 years, but so far no one's been able to prove that robotic total knee replacements are better than a manual total knee replacement. And I always stress to my patients that don't feel that you got shortchanged or didn't get the best technology by having a manual knee replacement, because in the vast majority of patients, it relieves the pain from the arthritis, it restores their function, and improves their quality of life. So thanks again for watching. Until next time, I'm Adam Rosen. Stay safe.